Head and facial trauma is where we're moving next. Let's go over a little bit about we have the cranial vault. Again, the cranial vault houses the cerebrum. It also houses CSF and blood supply and its blood vessels. So this enclosed space. We know we're not going to have bleeding out from there, but we can have increase intracranial pressure. Increase intracranial pressure can cause the cerebrum to be compressed. This compression can also move distally, compressing the brainstem. And so it's important to, when we think about compression of the brainstem, to think about our cranial nerves that descend from the brainstem. 2 for vision, 3 is for extraocular movement, 4 is extraocular, and 6. So 3 moves the eye up and in, 4 moves it down, 6 moves it out to the lateral aspects. 5th is our sensory for face. We have our 3 distributions, 1, 2, and 3. And then we have our 7 for expression, the facial nerve. We have a lot of blood vessels in the face, they're highly vascular. 8 cranial nerves for hearing, 9th and 12th are, 7th and 9th are also with the, 9th and 11th are with the tongue, and 12th is accessory. So then we have a lot of glands, blood vessels, there's tongue, a lot of bleeding and swelling can result. This can change and push the anatomy, causing an airway obstruction, causing it would be very difficult for us to manage as far as the airway goes. We need to think about managing the spine, so manual immobilization. When we look at the ears, we make sure we don't want anything coming out of the ear, and if it is coming out of the ear, then we never try to plug that up. We may think that there may be increased intracranial pressure. The eyes, we look at potentially injuries to the eyeball itself, the orbit, the bones around the eye. And how can we tell? Well, first of all, we would test some of our cranial nerves. We look at extraocular movements. We look at vision, and we look at the the symmetry of both eyes and the symmetry of the face. If there's some kind of asymmetry or edema or ecchymosis, or if the eyeball is rescinded or protruding, this can all give us an indication that there's something going on with either the face, cranial bones, facial bones, nasal bones, or potentially the eye. When we look at the eye, we have the sclera, which is the outer white part. We have the cornea, which is the clear part. The colored part is the iris, and then behind the cornea is the part that tends to our pupil. Behind that is our lens for vision. So we just do a inspection, look overall for symmetry, look to make sure that it sits in the places that it's supposed to be. Test the extraocular movements laterally, horizontally, and then visual acuity. Orbital fractures will cause the extraocular movements to be somewhat displaced. We'll note that the eyes will not move in what we call a conjugated fashion. So we have abnormal extraocular movement. The zygoma, temporal, nasal bones, or frontal bones may be displaced. These muscle attachments may cause the face to be deranged or asymmetrical. So look to see if that's what we're seeing. What we want to try to do is minimize any further injury and any further movement. As far as the nasal bone, we'll end up having some nasal fractures. A lot of times it's just the soft cartilage that's displaced, but we also need to make sure that they don't have any type of hematoma on that cartilage, as it can cause the cartilage to wear away, and we have a damage to the septum. A lot of times it's just a simple epistaxis, just some anterior pressure, ice compression, and avoid them from swallowing in his blood, as is a GI irritant. That will cause them to have nausea and vomiting. The hardest thing is to just have them stop doing anything for about 10 to 15 minutes. They're always going to want to continue to look, and if they blow their nose, we're going to have more bleeding. Again, the only time that we would not want to obstruct this is if we thought that we have some kind of vasoskull, cranial, or head injury where we have a CSF fluid leaking out. Zygomatic fractures, there are very obvious, you can tell. These are injuries that break across the bridge of the cheekbones, over the bridge of the nose, and just below the nose, above the maxilla. When these are fractured, they tend to elongate the face. It's quite it's a quite visual finding. These are called Lafort's fractures. So asymmetry of the face, jaw line doesn't line up. There's malocclusion of the jaw. This could also be just a fracture of the upper jaw, the temporomandibular joint, where they have malocclusion of the jaw. So we want to test that. Sometimes we put a 4x4 in between the two front teeth and have them bite down. And we'll pull on the 4x4. If they can't close around that, or if we pull on it and it causes significant pain in the TMJ area, then we would think that there's a fracture to the temporomandibular joint. They look at dental issues. If you find any dentation that has been lost or evolves, if it is kind of loosely hanging in the area, you may be able to minimize any further risk to it. If it does look like it may become an aspiration issue, or if it's lost, then remove it and bring it in with us. Again, try to keep it sterile, cool, moist, prevent any further injury. We'll see whether or not what the emergency department and their protocols and whether their practitioners will opt to do with that. A lot of times we deal with eye injuries, and most times it's just dust or particles getting in the eye, a gritty sensation, scratching, pain. Something feels like it's in my eye, is what they say. We want to try to flush that area out, and sometimes it's as easy to just take a cotton swab, twill back some of that cotton, make it into a fine tip brush, as you would say, a very fine tip, and moisten that down with sterile saline and lift up the eyelids. You want to try to extrope them, or to try to invert the eyelid and just lightly wash away and lush over with that Q-tip to waste out any debris. As far as burns or actual global injuries, let's try not to do any further injury. If there is something in the eye, we want to try to flush it out, sort of like alkali damage, liquefactive damage to the eye. We want to try to clear it out, unless there's some type of turmoil like welding or skiing. We want to kind of keep that away from any further damage to protect the eye. Sometimes we may see some redness. So now, redness on the sclera that interjects, that just shoots across in from the corner of the eyes into the white sclera part, usually subconjunctival or scleral type injections. The bleeding that results on the inside of the cornea, on the coloring part of the eye that fills up the anterior chamber, that's a hyphema. Now, a lot of these don't necessarily have a significant life threat. It's just that the subconjunctival hemorrhage may indicate that the person was strangulated or have been suffocated. Damage to or hyphema or blood filling up the anterior chamber could be a result of some type of trauma, but should resolve on its own. So these are not necessarily altogether just one single finding that will make them a life threat. Retinal detachments, the patient may be complaining of visual loss or curtain type of vision coming down on them, or they may see spots or flashes of lights or spots of lights that kind of dangle down, a curtain-like effect in their vision. Secondary to trauma. This may be atraumatic as well. Just bring them in. Injuries to the ear. We have the external ear, where we have the tragus, the antitragus. This is the tragus here. The antitragus is this part back here. We have the auricle here with the helix. And then we have the external canal. The external canal leads to the tympanic membrane. Tympanic membrane and the ossicles make up the middle ear, and then the inner ear makes up the cochlea and the semicircular canals, which are what cranial nerve is at. Now, when we look at injuries to the eardrum, and sometimes it's barotrauma, other times it may be some kind of external thing that goes in. Remember, we talked about external hearing loss or conductive hearing loss being more cerumen or impacted cerumen in the ear canal causing the hearing loss. The neck injury areas. So as we look at the neck, zone 3 is above the jawline, zone 2 is just above the windpipe area or the cricoid cartilage, and then zone 1 is below that. It extends down to the clavicle areas, these areas of the neck. And so we need to understand the underlying anatomy, the carotids, the vertebral arteries, subclavian arteries, brachiocephalic, jugular veins, the windpipe, the trachea, the glottic opening, the tongue, the esophagus. All these are areas that, as we come down and injure them, can cause significant injury. Again, the neck is one of the areas that is very difficult to control hemorrhage because it's non-compressible. We'd have to put some direct pressure and hold it there. Not to mention there's a lot of muscles up in the neck. This can cause, once they're severed or detached, can cause a lot of malalignment or disalignment and derangement of the anatomy, causing even the windpipe or trachea to be misaligned, can cause the tongue to then be obstructing the airway because the tongue is attached to certain muscles around in the neck. And so this can cause a lot of areas, not besides bleeding, but it can cause this malocclusion of the upper airway. So we'd like to see that the neck is symmetrical midline and no GVD or tracheal deviation going on, and that the airway is quite clear, the airway is open. Now we can see all the way back to the posterior pharynx. As we get down into the cranial vault, we mentioned about, we'll go ahead and continue this in the next presentation.